We'll get started. I'm Scott Podolsky, and I want to welcome you all back to the Department of Global Health and Social Medicine seminar series. We, of course, focused much of the series since March on COVID-19, but our department has approached COVID-19, whether it's social embeddedness, the challenges of evaluating and implementing diagnostics and therapeutics, or the need for robust contact tracing, through lessons learned from their work on other pandemics, including, of course, the ongoing pandemic of TB. These lessons have been hard-earned. As Courtney Yuen will describe to us, there's a gap between the best practices for managing close contacts of TB patients and the reality in Peru. The best practices include prompt evaluation for TB disease and treatment of TB infection in those at risk for developing disease in the future. Even though the national TB guidelines of Peru have included this guidance for years, a large implementation gap exists. Courtney has explored such barriers and steps to overcome them. She brings a unique and notable background to her work. She received her undergraduate degree in chemistry at Brown prior to receiving her PhD in chemistry here at Harvard in David Liu's laboratory. After spending 2 years as a science education volunteer with the US Peace Corps in Uganda and a year as a health financing analyst at the Clinton Health Access Initiative in Zambia, she spent 2 years working as an epidemic intelligence service fellow in the Division of TB Prevention at the CDC. She then joined the HMS Department of Medicine in 2014 and became an affiliate of DGHSM in 2015. In a short period of time, Dr. Yuen has performed remarkable work in detecting and confronting TB, especially among children. She played key roles in the efforts to produce the first global incidence estimates for children with drug-resistant TB, to produce mortality estimates for children with TB, and to estimate the potential impact on childhood detection of TB of screening the households of known TB patients. This work has been incorporated into the WHO's own pediatric TB estimates and to the Stop TB Partnerships policy brief presented to the UN General Assembly high-level meeting on TB in 2018. She's now assistant professor of medicine at HMS in the Brigham and assistant professor of global health and social medicine in our department. And we're fortunate to get to hear from her today on implementation research on improving TB contact management in Lima, Peru. And of course, we're delighted that she'll be followed by Paul Farmer, our department chair and Nicole Catroni's university professor at Harvard, before we finish with questions and answers, which you can submit anytime through the Q&A button on your screen. So we'll start with Courtney Yuen.
Thanks, Scott. Let me just share my slides. Okay, can you see my slides? Okay, great, thanks. All right, so today I'm very honored to have the first seminar slot after the COVID only focus. I don't know if that was intentional or just incidental, but I'm going to talk to you today about work that's been going on in Lima, Peru over the past few years to improve TB contact management. This is work that I've been doing in collaboration with colleagues in this department, but also with Socios and Salud, Partners in Health in Peru. And I'm really not going to talk about COVID at all during this talk, but that being said, I think there's some important parallels that can be drawn between contact management and service delivery for contact management for TB and COVID contact management. So I think, it's good to think about those parallels and maybe we can talk about them during the discussion. No conflicts of interest. So in terms of TB contact management, we know that TB affects families, friends, and communities, not just the patients who are sick. Close contacts are at high risk for TB infection and disease. And so when a person's diagnosed with TB, their friends and their family need care. They need to be evaluated for TB disease and infection, and they need the appropriate treatment, whether that's for disease or infection. One part of contact management is TB preventive treatment, and that I'm going to be talking about preventive treatment a lot today. So preventive treatment is a treatment given to prevent TB disease in contacts who are infected with the bacteria that cause TB, but who are not yet sick with TB disease. The use of preventive treatment is one part of a comprehensive approach to the TB epidemic. The Zero TB initiative, which is something that many of you may have heard Salman Khashoggi and Mercedes Becerra talk about, likes to use this graphic that I'm showing to show that A comprehensive approach to TB includes searching, treating, and preventing. So by searching, we mean actively looking for people who have TB and diagnosing them early. By treatment, it means giving people appropriate, effective treatment in a supportive way. And then prevention is, the use of preventive treatment to prevent disease from happening. And I'm really going to be talking about only the prevention part of this today, but of course the other parts are critical. In fact, a lot of my work does focus on the active case finding, that is the search part of this process. And of course, Partners in Health have spent decades writing the book on effective supportive treatment for TB. The global standard of care for TB preventive treatment is to give preventive treatment to contacts who are infected, but who do not have TB disease. This is what's long been done in the US. Up to 2018, there was a double standard in the WHO recommendations. So countries, high-income countries with low TB burdens like the US were recommended to follow this standard of care. But low and middle income countries were only supposed to give preventive treatment to young children and people living with HIV. In 2018, WHO released new guidelines that made a single recommendation for all countries and so eliminated this double standard. Later that year, the first UN high-level meeting on TB set a target for 24 million contacts to receive preventive treatment over the next 5 years. But current delivery systems in low and middle income countries are not on track to meet these targets. And this really isn't surprising, given that they're now being told to give preventive treatment to many times the number of people that they've been told to treat for decades. To understand the challenges in delivering preventive treatment, it's necessary to understand the care cascade. So first, contacts who are identified must be evaluated for TB disease and/or infection. So of course, any contacts who are diagnosed with TB disease at this point are treated. Generally, in low and middle income countries, young children and people living with HIV do not require testing for TB infection in order to receive preventive treatment. But other contacts are eligible for preventive treatment only if they have a positive test for infection. And that's more or less consistent with how things are done in the US. We will also give treatment to young children, even if their test is negative. So for contacts who are eligible for preventive treatment, a doctor must prescribe that treatment, and the contact must then initiate treatment, and then the contact must complete treatment. So the question is, how can health systems that have not historically prioritized TB preventive treatment and as a critical part of contact management, how can they effectively deliver these services and enable contacts to complete this multi-step process? The problem with the multi-step process is that many steps means many opportunities for losing patients. A 2016 systematic review estimated that less than 20% of people complete the TB infection care cascade. And notably, of the 65 cohorts included in this study, the majority were from high-income countries where treatment policies have been in place for a long time and health systems are not underfunded. The problem is that if at every step you lose 10% or more of your patients, by the time you get to the end, you have very few people left. The work I'm presenting today focuses on improving contact management in Caraballo district of Lima. This is an area where Partners in Health and Socios has been working for decades, with much of that TB work over these decades focusing on improving treatment for TB patients. Over the past 5 years, I've been working with Socios to try to improve management of the family members of these patients. As context, these are the guidelines and practices for contact management that exist in Peru. The guidelines say that all contacts of patients with TB should be evaluated. Doesn't matter what type of TB the patient has or the age of the contact. And of course, everyone who's diagnosed with TB gets treated. After ruling out TB disease, the recommendations for preventive treatment are age specific. So children under 5 years old are treated, given preventive treatment, similar to in other low and middle income countries. In Peru, the guidelines specifically say that contacts who are 5 to 19 years old are treated if they have a positive infection test. But then for older adults, so 20 years and older, the treatment is neither prohibited nor required. The guidelines really just don't say anything explicit about adults. They do have a general statement about how doctors can use their judgment to prescribe preventive treatment to people who are at high risk, but there isn't a really clear statement. In terms of the practice, TB contact management takes place in primary care facilities. This is the same place that most TB treatment is done. Treatment is only available right now with 6 months of isoniazid, which is taken daily, but dispensed weekly and self-administered by the patient. To give you a sense of the starting point for the work that I'll be describing, here's the care cascade of child contacts under 5 years old from 2015, which is before we started working on this issue with socios. You can see that every step of the cascade, around 20 to 40% of the children are being lost. So that at the end, only around 20% of the children who should have completed preventive treatment, in fact, did. Now, children under 5 years old are the contacts who have traditionally been most highly prioritized by the healthcare system. So this cascade looked even worse for older children and for adults. I'm going to describe 2 interventions to improve contact management that were implemented in socios as part of an ongoing Zero TB initiative effort in Lima. I just want to point out that, like I mentioned, preventive treatment is only one part of a comprehensive approach, and this work was being done in the context of larger programs that also focused on treatment support for TB patients and active case finding to improve detection of TB in this district. The first intervention, which was implemented in 2016, was part of an individualized accompaniment program for households affected by TB. Socios provided intensive case management and care coordination. So case managers would help to make clinical appointments for contacts, and they would travel with them from their homes to those appointments, paying for transport. There was no attempt to change the services in the health system, though. So the strategy was to maximize people's access to the existing services. The second intervention, which we implemented last year, fundamentally sought to change service delivery. Socios worked with the health system to implement new delivery models, including home-based TB infection testing and X-ray mobile units in communities that provided TB diagnostic services closer to where people lived. There was also a concerted effort to support capacity building in the primary care facilities for preventive treatment management. And there was still community-based treatment support for patients and their families. It's worth noting that the first intervention reached just over 300 contacts in 9 months, while the second reached over 1,000 contacts in the same time period. Now, part of the reason for this is because there were in fact more TB patients last year than in 2016 because of this active case finding that was going on, as well as population increases in the district. But the main reason for this difference is that the first program was offered by socios as a service that was additional to routine care, which patients and their families had to accept voluntarily. So around 40% of index patients actually refused to let socios visit their families. And then once making that home visit, some of the family members didn't actually want this to participate in this program. But in the second program, socios worked with the health system to effectively change the standard of care. So this new system of routine care became the standard of care, and everybody had access to it just kind of by default. So in the end, it reached over 3 times as many people. And I just want you to keep in mind the different scales of these 2 programs in the subsequent slide. That is the fact that the second program reached over 3 times as many people as the first. Because I'm not going to be showing any more numbers for the rest of the presentation. Of course, the papers reporting these interventions do have numbers and statistical tests and all that good stuff. But for the purposes of this presentation, I really want to focus more on kind of the big picture lessons learned. So what is the big picture? Well, to me, the big picture is understanding that we tried 2 fundamentally different approaches to improving contact management, and that the implementation research that we did around those approaches has taught us some important lessons. So this graphic's going to illustrate the existing system in Peru for contact management, before we started any of this work. A contact's first point of entry into the healthcare system for contact management is the health facility that's nearest to their home. So all the neighborhoods in Peru, they're all people belong to a jurisdiction of a specific health facility. So they're supposed to go to this health facility for all their TB services and other care. The problem is that many of these smaller facilities do not have the capacity for X-ray or TB infection testing. So oftentimes, after completing this initial evaluation and registration, the patient would have to go to a larger primary care level health center in the district to be able to get the X-ray done and to do the TB infection testing. And the problem there is that because the primary care doctors in this setting often lack confidence in their ability to effectively diagnose or rule out TB, especially for children, contacts were sometimes being, or actually quite often for children, being referred to a regional hospital for an evaluation by a pulmonologist or a pediatric pulmonologist. So then once the pulmonologist makes their decision of whether this child needs, or this contact needs TB treatment or preventive treatment, then they go back to that health facility near their home to actually get the treatment. So the accompaniment program did not fundamentally change this pathway. It supported contacts through the pathway by walking with them every step of the way, but it didn't actually change the path that the patient had to follow. And as you can imagine, this is labor intensive, both for the accompaniment program as well as for the patient. So even if it's effective, it would potentially run into problems with trying to scale up these services. In contrast, the intervention that we implemented last year fundamentally changed the patient pathway. So Socios delivered home-based testing for TB infection. Contacts were then able to get their initial X-ray and their evaluation done at a mobile unit operated by Socios when it was located near their homes. Contacts could then go to their local health facility with the X-ray films and the initial evaluation results in hand. And we contacted the pulmonologists to come from the hospitals to go to and visit regularly these primary care facilities in order to help the primary care doctors make diagnostic decisions. So the pathway for the patient became much shorter, both in a geographic sense and just in terms of the number of places that they had to go. So I'm going to go through each of the steps of this contact management cascade and describe the impact of the interventions that we implemented and the lessons that we learned. As I just described, the two interventions took different approaches to improving evaluation and testing. For evaluation, the accompaniment program focused on helping patients access the existing services through coordination and intensive individualized accompaniment, including paying for transportation. But the community delivery program brought the evaluation and testing services closer to people's homes through these X-ray mobile units and through bringing the pulmonologists from the hospitals to the primary care facilities. And the hope was that by increasing the convenience for the patients, for the contacts, this would lower the access barriers enough to make this individualized accompaniment unnecessary. So I just want to show this photo so that you know what I'm talking about when I keep mentioning these X-ray mobile units. This is the mobile unit that's been having really great success in improving TB diagnosis in Lima. I have an entirely different presentation just on this program, which is really great. That the program is doing really great things. I mean, not that the presentation is really great. But I don't have time to go into that extensively today. So just to describe briefly, the van that you see in the foreground has an X-ray machine in it, and the X-ray machine is equipped with automated detection software that instantly reads the X-ray and triages it to being either abnormal or normal. And so if the person has an abnormal X-ray, then they can get a medical evaluation, a clinical evaluation in one of these tents that you see in the photo, and they can also get sputum collected here, and the sputum is taken to the Socios lab for rapid molecular testing. So this graph shows the percentage of contacts who were evaluated for TB. For all the graphs in this presentation, they kind of all have the same structure. So the 3 sets of bars show the 3 time periods: the pre-intervention period on the left, the 2016 accompaniment program in the middle, and the 2019 community delivery program on the right. The green bars are children under 4 years old, or sorry, under 5 years old. The purple bars are people 5 to 19 years old, and the gray bars are people 20 years old and older. And these are the age groups that are used in the preventive treatment recommendations, so that's why they're split that way. The height of the bars shows the percentage of the contacts who completed that particular step of the cascade out of the ones who should have completed that step. So you can see that compared to the pre-intervention period, both of the intervention strategies substantially increased evaluation, particularly for older children and adults who were previously being lost from care. But then if you look at how many of them were actually getting TB infection testing, there's a different picture emerging. So it was very low to start with in 2015, and it really improved quite modestly during the accompaniment program. The major reason for this is that there was a global shortage of the tuberculin skin test reagents, and the larger health facilities in the district actually did have the reagent, but they were reluctant to use it for fear of running out. So this is kind of illogical if you think about it, because there's no point in hoarding a reagent if you're never going to use it for anybody. But that's effectively what was being done. And so socios could get the contacts to these health facilities and could request the testing, but if the doctors would not order the test, then the contact wouldn't get tested. So this to me illustrates the limitation of the accompaniment approach. You can bring a person to the health services, but if the health services themselves are insufficient, then care will not be delivered. So in contrast, when socios offered home-based testing, nearly all contacts accepted the testing and got tested. So I think the lessons here are that to address service delivery gaps, you can either bring the patients to the services or you can bring the services to the patients. The advantage of the strategy of bringing patients to services, I guess you can consider this an advantage, is it does not require investment in the health system, which may be an advantage in terms of program planning and perhaps financing, depending on who's implementing the program. However, it cannot overcome existing limitations in the health system. And the labor intensiveness makes it problematic to scale up. So I think the strategy may make sense when there are small numbers of patients and the health services are adequate but hard to access for geographic or financial or logistical reasons, but it's not great when you're trying to deliver services to a large number of people. So bringing services to patients requires investment in the health system, but a more community-centered service delivery system may then require fewer human resources to ensure access at scale. So for TB prevention, because we know that the existing services are not adequate and the number of people requiring care is quite large, investing in new community-centered delivery platforms is necessary. Once contacts have been tested and evaluated to diagnose or rule out TB, doctors should be prescribing preventive treatment to those who are infected but not sick. However, this doesn't always happen. Here are quotes from providers during a focus group that we ran about the reasons why preventive treatment is not being prescribed. They pointed out perceived limitations in the guidelines as well as an awareness among providers. So a pulmonologist pointed out his perception of the national guideline was that latent TB was not being prioritized in the guideline, just based on the fact that there was like one page dedicated to TB infection as opposed to the many pages dedicated to TB treatment. One of the nurses mentioned that this absence of an explicit recommendation for adults. She said it would be good if they could just come out with positive PPD or IGRA or some other indication. She wanted the guidelines to just be clear. And then a doctor at one of the primary care facilities said that, amongst his colleagues, the doubts about the effectiveness of preventive treatment are widespread. People lack information, lack technical expertise, and lack awareness. So what do we do about this? Well, in the accompaniment program, we honestly did not do that much because the program was not attempting, it hadn't really been planned to change practices within the health system. So we made posters stating the national guidelines, and we hung them in the health facilities to try to create awareness. But we didn't do anything more involved than that. But in the community-centered service delivery program, we actually did try to tackle this issue. So we contracted pulmonologists from the local hospitals to visit the primary care facilities, as I mentioned, and the intention was both for them to help with the evaluations, but also to mentor the primary care doctors and to give them information about preventive treatment. And also our own doctors from the Brigham, so Gustavo Velasquez, Dylan Tierney, and Salman Khashoggi, helped to create guidance documents on side effect management which the Peruvian doctors didn't have. This graph shows the percentage of contacts who had an appropriate prescribing decision after being tested for TB infection and having TB disease ruled out. So for the children under 5, the testing was not actually required. They should have been prescribed treatment after evaluation. For the other age groups, an appropriate prescribing decision would mean that they got prescribed treatment if they had a positive infection test, and they should not have gotten treatment if they had a negative infection test. So you can see that posting the guidelines in the health facilities made a small difference, but the supportive visits from the specialists helped to improve prescribing further. And this, in the context of the home-based treatment program, home-based testing program, resulted in a substantial improvement in getting adult contacts access to preventive treatment. So in the earlier time periods, none of the adults were being tested or even considered for preventive treatment. So that's why that gray bar is just absent. So this is very much a work in progress, and we're still looking at how to develop scalable strategies for improving health system capacity for managing adult and adolescent contacts in particular. So these are the contacts that the health system really isn't as used to managing because they haven't been prioritized. One strategy we're exploring is academic detailing, which is an individualized educational outreach strategy that's been widely used in the US to change prescribing practices. It's based on pharmaceutical marketing techniques. It uses repeated one-on-one visits to doctors by educators who are trained in social marketing. And these educators use a kind of motivational interviewing technique to deliver tailored messaging, as well as offering support for clinical decision-making. And we're developing this intervention in collaboration with the National Resource Center for Academic Detailing, which is at the Brigham. So once a contact starts treatment in Peru, they currently have to take pills daily for 6 months, and they have to return to the health facility every week for medication refills. In their own words, here's what family members of TB patients find difficult. They described medication fatigue. A caregiver said that her daughter took the pills for the first month, then she got tired of it, she was sick of it, she didn't want to take it. She shouted and cried, "I don't want these pills." The weekly medication refills were also a challenge. An adult on preventive treatment said that she was busy caring for her bedridden father. And the people from Socios called her and said, "Why are you not coming to pick up your medications?" And she said, "Look, what happened is that I did not have time." Finally, the fear of side effects was an issue. The third quote describes a grandmother arguing with her daughter over whether the granddaughter should continue preventive treatment. The grandmother wanted the granddaughter to keep taking the treatment, but the mother refused because of fear of side effects and ultimately stopped the granddaughter's treatment. In both programs, we used educational materials that we had designed to help with counseling for contacts about preventive treatment, explaining to them, what it was, what it was doing, what the side effects are, when they should contact the community health worker or their doctor. For the contacts who initiated preventive treatment in the accompaniment program, Socios offered home-based directly observed therapy, and in the community delivery intervention, this was changed to a menu of support options, and I'll describe these further. So at first, home-based directly observed therapy seemed like a natural solution to this issue of completing preventive treatment, because it was an extension of Socios's program of home-based directly observed therapy that's widely used for TB patients. While the term directly observed therapy emphasizes this idea of observation and adherence, and I don't particularly like this term or the practice necessarily, in practice, the Socios program is actually less about observation and more about support and accompaniment. So trained community health workers make daily visits, they bring medications, they provide counseling and emotional support. But when we tried offering these daily visits for preventive treatment, we encountered limited acceptability. Many index patients would not consent to allow the Socios team into their homes, and even amongst those who were visited, contacts who were visited, many caregivers refused the visits. So in the end, the program really didn't reach all the people who could have benefited. In addition to these acceptability issues, or perhaps related to them, there are several logistical challenges when you think of like how to make a general and scalable program. So first of all, with many more people receiving TB preventive treatment than TB disease treatment, human resources is an issue for making daily visits to everybody. And then secondly, the people taking preventive treatment are not sick or confined to their homes as TB patients are. So home visit is not necessarily the best way to support them. And this is especially true for like adults who may be working or older children who may be in school. In the community delivery program, we instead offered a menu of support options to all contacts initiating preventive treatment. We offered either home visits or phone calls by a community health worker, and visits could be weekly, every 2 weeks, or monthly. We also offered automated daily SMS medication reminder messages, and we provided everyone with a point of contact in case of concerns or side effects. We found that everybody wanted some form of support, but what they wanted differed. Almost everyone accepted the SMS reminders. The few who didn't were people without phones. 60% requested home visits, while 45% requested phone calls. And these numbers sum to more than 100% because some people wanted both. So for instance, people would ask for weekly phone calls, but a monthly visit. And 19% requested something else, generally either for a community health worker to visit them at a place that wasn't their home, like their workplace, for example, or for help with medication delivery to get around this challenge of having to pick up medications weekly. This slide shows treatment initiation on the left and treatment completion on the right. There are a few conclusions I think are important from these graphs. One is that without any intervention, children up to 19 years old, so the green and purple bars, in this population, we're quite good at initiating and completing treatment. These are much better results than what's been reported in other settings. Another conclusion is that if you focus on the gray bar on the right of each graph, you'll see that adult contacts initiated and completed treatment as well as the children. So we don't have a historical comparison for this since adults weren't getting prescribed preventive treatment before last year. But I think we can say that high initiation and completion among adults is possible. And this is something that a lot of people doubt in programs that have never tried this because they say, oh, adults like won't take medications, they're working, they don't have a caregiver who's prioritizing it. But I think that's not what we saw in this program. Now, I think what we cannot say from these graphs is that the interventions had a significant impact on the percentage of contacts who initiated or completed treatment. But I think what this kind of quantitative data does not show is whether the intervention helped make these processes any easier for people. When we conducted focus groups with contacts who had received preventive treatment, and we asked them generally about the things that helped them during treatment, they mentioned a mixture of facilitators, some of which were related to the intervention and some of which were not. So for example, one common facilitator that was not related to the intervention was family support. Several people mentioned that having a family member who could pick up the weekly medications for the whole family was helpful. But other participants mentioned things that actually were part of the intervention. So for example, the second quote is one of many quotes where people talked about the community health workers and the emotional support that they provided. So this person said, God bless these people who take their work so seriously. They take everything seriously and make us feel like we're part of the family. My husband and I are very thankful for this. So something like this is not necessarily going to come out in a graph comparing treatment completion, but clearly this was a beneficial relationship for this person. Some people mentioned finding the SMS reminders helpful, although others didn't. And so I think this also just shows that, different people need different things. So the lessons learned, I think, are that, treatment is long and inconvenient. People don't want to take pills for that many months, and they don't want to have to pick up their pills weekly. There are shorter preventive treatment regimens available and pediatric formulations that are easier for children to take. We did focus groups where we described the options and asked people about their preferences, and there was definitely a demand for these more patient-friendly options. And I think we can say that people want support, but that different people want different types of support. And a one-size-fits-all approach is probably not, going to work to just give everybody the exact same support package. I also think we can say that home-based directly observed therapy may not be a good solution for this particular issue. So this slide summarizes all the strategies that I've described so far and how they each sought to improve each step of the contact management cascade. Of these, I think the only one that we decided was not worth pursuing further was the home-based directly observed therapy for preventive treatment. And of course, the academic detailing approach is still being developed. So hopefully we'll find out whether that is a good solution for this particular issue in the upcoming years. But at the end of the day, all of this work is still a work in progress. This graph estimates the percentage of infected contacts who made it to the end of the care cascade. In the first 2 time periods, it's quite a rough estimate because so few people were being tested that we have to make assumptions about how many people were actually infected. But currently, we estimate that around 40% of children up to 19 years old are making it through the cascade and less than 20% of adults. Now, this may come as a surprise given that all the earlier graphs show that the majority of people were completing each step. But remember, if you lose 15 to 20% of people at each step, by the end of a 5-step process, you end up with a relatively small percentage making it to the end. And also remember, high-income countries like the US aren't doing that much better than this. So this is just to say that we all have a lot of room for improvement. Here are some strategies that we're currently looking into to further improve contact management. So for home-based TB infection testing, I really didn't describe the details, but the system that we used was interferon gamma release assay blood tests. So this involves taking blood in the patient's home, which was relatively simple. But then once all these blood samples made it to the Socius laboratory, there was quite a bit of laboratory infrastructure, sample processing, equipment needed to actually process the assays. And Socius could do this because they have the laboratory infrastructure. But in other places that might be a barrier. So there's new platforms, new systems that currently make that kind of reduce the need for laboratory testing that can use those blood samples in a simple kind of laminar flow, like a dipstick type system. So we're looking into that as a possibility. We're still very actively trying to figure out scalable strategies for capacity building for preventive treatment at the primary care level. I mentioned academic detailing, but we're also exploring the idea of Project ECHO, which is a kind of virtual communities of practice system that's actually being used here in Massachusetts to try to improve the capacity of primary care physicians here to manage preventive treatment in high-risk groups. And finally, we really want to be able to introduce better TB infection treatments into Peru. Shorter regimens and pediatric formulations, we know that the contacts want them, and it's a matter of getting them approved and getting them in the country. So in conclusion, good contact management for families affected by TB is challenging. It's a multi-step process, so there's many opportunities for people to be lost at each step. And interventions that are targeted at closing specific gaps are gradually, I think we can say gradually improving contact management in Caravaggio. And I think that generally speaking, even outside the specific setting, I think that we should really think about community-based delivery platforms as a strategy for achieving the necessary scale-up of TB preventive treatment in high burden settings. Health systems are being told that they need to put 10 times as many people on preventive treatment as they're currently doing now. So it's just silly to think that the health system without any investment is going to be able to do this. We obviously need massive investment in the health systems to be able to reach these UN high-level meeting targets. And so while making those investments, now's the time to think about how do we perhaps improve delivery models. So finally, I just want to acknowledge many people, including a very large team at Socios and Salud who really implemented all this work. Few key people are mentioned here, but there were a lot of people involved. Here at Harvard Medical School, our team led by Salman and Meche, and many other collaborators who have contributed, as well as our funders. So thank you very much. I'm going to stop my slide share, and then we can answer questions.
Courtney, thanks so much for such a rigorous analysis of all the steps along the care cascade. And I just want to remind our audience members that if you have questions for Dr. Yuen, please submit them through the Q&A at this point. But first, we'll get to hear feedback from Dr. Farmer.
Well, thank you very much, Courtney. This was a very fine-grained analysis of a perplexing problem that's been of long-standing debate, as you know, and as you summarize. I mean, basically, we have an intervention which could substantially reduce the number of incident tuberculosis disease cases that's been well known or been identified for some decades, but has never been widely taken up. And of course, it has been taken up in some places more than others. So the question of how widely is an important one. And then looking back over the last 80 years at the debates around this, what are the claims made? I mean, how many have said, well, these are asymptomatic people, we're intruding on their willingness to get involved in undertaking any risk at all for what is essentially, the prevention of some adverse event that may occur in the future. So that's been the nature of the discussion, as you said, Courtney. How do we account for this failure? And before we leave COVID altogether, which I don't think we need to do, because we're going to learn lessons from TB control that are relevant to COVID. Before we leave that, it is, as Scott said at the beginning, how do we understand social embeddedness? And that I think is front and center in your study, is how do we understand social embeddedness? But it takes a while to reach that point, of course, because of your methodological modesty and our own. And so let me just get at some of the checklist of matters that you brought up, comparing tuberculosis, the treatment of latent tuberculosis infection with past efforts, which have been unremarkable. Let me just add in, there are important lessons to be drawn about COVID. First of all, I want to also say thank you for adding to this whole notion of implementation science or delivery science. That is, we have some discoveries, and in this case, we're talking about a long ago discovery that even one agent like isoniazid may prevent the recrudescence of active disease, right? That's the discovery. And then the development of tools, in this case isoniazid, but there will be others, as you said, and we'll hear about how there need to be pediatric formulations for these agents, right? And then finally, after discovery and development, we have delivery. And here you've shown us that the delivery part of this is just as critically complicated as the discovery science itself and the development of these tools. For example, sorry. For example, if COVID, the specifics of COVID reveal emerging understandings, that is, you could reasonably argue we don't know yet the specifics of the disease, you can't really argue that with TB, what we have here is not evidence of emerging understanding, but evidence of really deep ambivalence about what to do with latent infection. And you know this because you've been deeply involved in this. It's as if people are not, and when I say people, I mean not only family members and contacts, but the public health authorities are ambivalent about how much to move on this. And of course, this is obvious to you because you've been in the thick of it, Courtney. But on this COVID versus TB analysis, we can just see going through a checklist that we have a lot to learn from TB. For example, is this a disease in which we need to identify close contacts and support them in one way or the other? Yes, it is. Is this a disease, COVID, where we should engage in active case finding in order to prevent transmission? Yes, it is. Is this a disease that's now pandemic for which we have emerging global standards? Yes, we do have that even with COVID, which is why we have to ask these hard questions about why emerging TB standards have been so controversial over all these decades. I mean, for heaven's sake, not to be able to get recommendation for adults in Peru after decades of elaboration of the national TB program. Is this a disease for which active support is required, even though it's an acute disease compared to tuberculosis? Yes, it is one of those. Active support is required, not just for management of active COVID disease, but for promoting contact tracing. Is this a disease for which effective prevention and care might be integrated profitably? It is that also. Is it one for which we have post-exposure prophylaxis? Well, here is a place where things fall apart. We don't have a effective TB vaccine. We don't have an effective COVID vaccine, but we do have effective post-exposure prophylaxis. Now with COVID, and Courtney, forgive me if I am returning to COVID quite a bit. With COVID, we don't know if we have effective post-exposure prophylaxis. You know, when President Trump got COVID, he received 2 medications which might reasonably be considered post-exposure prophylaxis, an antiviral and a monoclonal cocktail, right? The purpose of which is therapeutic, but also to prevent the development of later complications. So even here, I think the insights that you've gleaned from tuberculosis over the years, Courtney, are of enormous importance as we contemplate the leading infectious killer of young adults in Lima as in Boston, which is almost surely COVID, another respiratory illness. So I think there are lots of reasons for us to be grateful to you, Courtney, for plunging into this topic over the last few years. And one of them is because we will also have post-exposure prophylaxis for COVID. And so we'll be faced very shortly, if we're not faced now, with the challenge of what do we do to lessen secondary transmission. So again, I just want to say it's so important, this work. I also want to turn very briefly to one of the chief discoveries of this, which I'll use my own terms to put this in. It seems to me that what you've described is anytime you can remove, the choices of those who might choose not to pursue post-exposure prophylaxis, whenever you can replace those with clear algorithms or instructions, things tend to go better. And again, this isn't surprising to a lot of behavioral economists who write about this, the nudge that leads people to do the right thing. So, I do think we have to struggle with this, that whenever we give agency to those who might say no, and these are often public health authorities, as you said, pulmonologists, but they've been brought in before, right? Family members, school teachers, employers, neighbors, anybody who might say no, whenever we incorporate the chance of saying no, we tend to do it more and more. So removing the option of no is part of what I think you've described. And that, of course, is exactly where we are right now in the United States with a mask mandate, right? Why is all this discussion going on about, should it be a mask mandate or should it be strongly recommended in every circumstances and required in some? I mean, these are the margins in which you have, I was going to say wallowed, but that doesn't sound right. These are the margins in which you've engaged as a researcher, Courtney, is to say, how much are we going to get out of making, and then fill in the blank, required? Is it required for children to receive isoniazid prophylaxis or some other prophylaxis prior to returning to school? If it is, that's what's going to get you, closer to, or something along those lines is going to get you closer to the outcome. That is removing the option of not protecting oneself and one's community. And then finally, if I could just add one thing before opening this up, Scott, to Q&A and back and forth. I take it from the way you presented, Courtney, that you're comparing accompaniment to a community-based intervention. But as a minor aside, I would not restrict accompaniment to whatever it is that's defined at the moment in Socios or in any other place, right? So accompaniment needs to be an elastic enough concept to incorporate what is required to get to point B, to the outcome desired, in this case, successfully adhering to a post-exposure prophylaxis regimen. So, I mean, for example, when you talk about weekly med refills, and accompaniment, it seems to me that whatever is the barrier to filling one's weekly med refills, and I know I would have trouble with that. I can't imagine why the great majority of people asked to fill their meds on a weekly basis would not have trouble. It seems to me everybody would. So why is it accompaniment to have a weekly refill regimen? And again, I think we should use the term accompaniment to describe the interventions necessary to get to point B or the outcome, not to describe whatever the rating fashion may be. Like DOTS was in the 90s, was directly observed therapy. But if you actually did the ethnographic research in Peru, you found out that all the DOTS was facility-based. That's right. These were not, people who were interviewed and said, hey, would it be more convenient for you if we went to your home? They were people who had to go to facilities to have their directly observed therapy. So again, which one is more the accompaniment version? It's the one that makes it more likely that we'll get the job done. And that is almost always in Peru, as in the United States, whatever intervention that makes it more convenient to the patient, and in this case, the asymptomatic patient. And I would move all of that under the definition of accompaniment, although that's just a minor aside. And I hope it's not a defensive one. Like, I don't care that much whether or not the term accompaniment survives. What I do care about is what you care about, is can we lessen the chances that we'll have ongoing incident cases of slightly drug-resistant disease that will then be parlayed into highly drug-resistant disease. And again, I want to thank you, Courtney, not just for this superb presentation, but also for this hard work you've been doing in Lima, along with many others over the last few years. So thank you. And Scott, back to you.
Great. Well, thank you, Paul, as always. And Courtney, I'd love to give you a chance to respond to Paul.
Yeah, so I just want to say, so that, first of all, the accompaniment thing, yes, totally agree. I don't want to quibble about terminology. I was just trying to think of names for the two different approaches. Ultimately, we want things to be easier to the patients. And I think the conclusion is the more stuff you can move closer into the communities, the better it is for the patients. I just wanted to respond to just one. To me, like, I agree. The parallel here with COVID is that you can have the therapeutic, but the devil's in the delivery. And I think we're going to have that problem, when the COVID, people are already preparing for this, right? When the COVID vaccine comes out, especially the vaccines that they're talking about now that have that have severe like cold chain requirements for transport, how are these things going to be delivered? And I think as much thought needs to go into that as in delivery. Otherwise, it doesn't benefit you, or it doesn't benefit the vast majority of people for you to have that therapeutic.
I think first of all, that's the first time I've heard that lovely expression that the devil is in the delivery. And I think that's the take home message of this work. And the reason I kept going back to COVID, Courtney, is because I would not want you to underestimate the relevance of your work on latent TB infection to the challenge that we now have before us. In fact, I would say it is highly relevant, even for reasons of pathophysiology alone. That is, a lot of people who are infected with the novel coronavirus will be asymptomatic or largely so. So again, another reason to learn from the #1 infectious killer of young adults until it was replaced by COVID, and that's TB.
Yeah. And the other thing, the other point I wanted to make was something you said very early on about, what's the, how do people talk about, what's the source of this ambivalence, and how do people talk about the benefit of this? Oh, you're preventing people, but some of them might not have gotten sick anyway. I just want to point out, so there was a JAMA article this year that was estimating the number needed to treat for TB preventive treatment. And it ranges from, under 10, when you're talking about young children, young child contacts, to around 180 when you're talking about adult contacts who have had a long-standing infection test. They might have gotten infected years ago, et cetera. So like, that's kind of the bounds. And if you look at the number needed to treat for statins to prevent one non-fatal heart attack, it's over 200. Yeah. And with statins in the US, we're talking about giving them to like a third of the adults in the US, right? Or something. I mean, just the scale at which statin use is being talked about accepts that risk benefit without question. Whereas for TB, we're really hung up on that risk benefit. And I think that, yes, you can say, oh, well, there's issues with adverse events, et cetera. But I think that fundamentally it's because of who has it, right? Like it's.
Well, I just hope, Courtney, that you'll keep, thinking and writing about that as well. And that's probably why we're so fond in the social sciences of, comparison. In the yield on the way chemists look at this, which you've obviously not adopted, the yield on the way that chemists look at these problems, I think, is so high because of the narrow specificity, which you also have embraced. But here, with this problem, the more that you, Courtney, could think and write about the source of this ambivalence, and interview people like Salman, of course, and others who have been in the thick of the policy debates, the origins of it, the contours of it, are going to prove relevant in discussions of response to COVID as well, of course. Yeah. But thank you very much for letting me respond. Thank you.
Thank you. I also noticed that there's somebody actually typed a Q&A, so I just want to make sure I get to that.
They did, sure, Courtney, we can get to that. Let me ask just one question. I mean, along the lines of what you were just talking about, what were the origins of the 2018 double standard? I mean, we can imagine them, and then how were they actually changed? What types of machinations led to that change?
Yeah, I mean, so the origins of the double standard, I am not a historian, but there has been a book written about this. It's like Christian Macmillan's book about the history of TB policy. And it was after the trials that had showed that preventive treatment was effective. It's just a resource issue. People, so the health systems in low and middle income countries are never going to be able to deliver this. They can't even get themselves around delivering treatment to the patients. So there's really just no chance that it's going to go anywhere. So
I mean, again, this is just a suggestion for the struggle of understanding, not because I know, but then where did it come from? these confident claims about what was possible and what was not possible. Literally, from whom did it come? And, I think a lot of it, the origins of it, actually case by case, recommendation by recommendation, policy by policy. A lot of it went through in the 70s and 80s, the TB expert community, as it was being inundated by ideology from development economics. And, so these two regimes, really explanatory and action regimes of cost effectiveness and I'm just going to say the TB control community that embraced DOTS, they emerged at around the same time in the 70s and 80s, and again, the historians will have a lot to say about this in time, but Courtney, I believe you have a lot to say about it already.
Great, thank you both. And Courtney, I will let you get to the question that was asked, because I know we're at our end time soon. It says, thank you very much for your wonderful presentation. Totally agree. I wonder if part of your work looked at monitoring the adverse effects people with LTBI using the TPT regimen may experience. Do you think this is an area that we can look into to get their lived experiences with adverse effects? This is an area of interest to this particular audience member. Thank you.
Yes, thank you for the question. Yes, so the answer is yes. We did monthly adverse event monitorings with questionnaires, so we do know kind of what was, how people were experiencing them. As consistent with what's known about this regimen, it was worse for older people than it was for younger people. And in the focus groups, a lot of the people who didn't actually complete treatment, it was because of adverse events. So, I guess I can't say that from focus groups. Some of the people who didn't complete, this was the reason. So we know it's an issue, and we also know that there are preventive treatment options with fewer adverse events, and there's ways to avert these adverse events. For example, like giving vitamin pyridoxine with when you're giving isoniazid. And neither of these things have been adopted by the Peruvian health system, neither the newer regimens or giving pyridoxine, even though we were actually pushing them to do both. So, it's an area, definitely an area of improvement.
And Paul, it sounds like you had thoughts on this as well.
Well, no, I was just typing in some more enthusiasm. Maybe we have a chance for a couple other questions or one of yours.
Sorry, yeah.
That could be me.
Yes, this is Paul saying yes. Paul Farmer says, Courtney, this is such a great presentation. It has so many implications for delivery science in general. I totally agree. We all have passed our limits. This was wonderful, Courtney, both and instructive, whether with respect to, as Paul says, TB, COVID, or any infectious disease or diseases generally. So thank you very much. As always, it was a fantastic talk. Paul, thank you so much for your thoughtful input as always as well.
Thank you, Scott.
Great.
And sorry to whoever wrote that question about the adverse events. Yes, please feel free to email me. They said I was trying to type a response and fumbled it. So yes.
Great, thank you all. And I think our pro seminar series resumes next week at Wednesday at noon. So certainly please join us then. Thank you, Courtney. Thank you, Paul. Thank you, Carol and Casey, for always making this happen. And we'll see you all soon.